In this case, is a 71-year-old female with a deformity. She's a degenerative scoliosis. She has mild back pain, but lots of claudication and radicular pain, and there's her pain drawing there. But the thing to note on the right is that she's very well balanced in terms of her deformity in the coronal and sagittal plane. So if the problem is mild back pain, but the major problem is leg pain, then one technique that you might do, and the way I think of it, is if I can stop the pain with a selective nerve root block or transpyramidal block, diagnostically, that is the kind of patient that we can decompress alone and hopefully avoid a fusion. And since we can do it pretty fast, that is sometimes preferable in a fragile patient rather than do a large scoliosis fusion. So that's what we did in this lady. So here's her pre-op MRI, and you can see where the foraminal stenosis is. On the left, you see where she's got these large osteophytes in the concavity of her curve. And on the left side, sorry, on the right side in the upper part of the curve, and then the fractional curve on the right. And her MRI sagittal views show where her foraminal stenosis is, and then the axial views at the 2, 3, 3, 4, 4, 5 levels show you where the decompression needs to occur. At 4, 5, we're going to do central lateral recess, and mainly, and we'll, depending, and I don't recall right now which side we did our nerve block, but wherever that side is, that's where we're going to do the foraminotomy. And you can do multiple foraminotomies through a single portal from a far lateral, particularly in the concavity of a curve. So your technique depends on where you want to go. You put the tubular retractor. In this case, we were going in the midline for our laminectomies 3, 4, 4, 5, and 5, 3, 4, and 5. And we can do mediofasciectomies and foraminotomies from the ipsilateral side. And again, remember I was talking about the burrs. You can also dome the lamina with the burrs to get a complete central decompression through a single portal. And then if you need more, you can go on the far lateral side like you should. Okay. There you're seeing the dura at the 12 o'clock position that has been decompressed with the burrs, and pretty thoroughly. There's the nerve root on the right side at the 3 o'clock position. Pretty happy with that decompression. And underneath that nerve is where we burred out the end plate, the ventral end plate. And that would be in the central portion of the diameter of the tube. So on your left schematically, you can see in relation to how you put your tube in, where you set it, depending on where you want to decompress. So I will decompress right through there for a central and lateral recess, ipsilateral, and even contralateral, and I'll go far lateral, usually about the width of my palm, about 9 centimeters, or where the patient's trunk is starting to curve over the side. That's where I'll approach for the far lateral. So in this 70-year-old lady who preoperatively had 5 out of 10 back pain, but the leg pain was more significant. Her big problem is she couldn't walk because she just couldn't stand up. She was on hydrocodone every 6 hours and gabapentin. 2 weeks post-op, when she came in for her post-op visit, no back or leg pain. She had a 4-hour drive to the office without discomfort, and she was only taking tramadol and naproxen. So that was a good solution for her. I'm not saying that's for everybody, but the key things in this case is that she was well balanced in her scoliosis, so we weren't fighting the mechanics of the curve. And 2, we were able to stop the major portion, or at least diagnostically identify the major source of her pain, and then could put this solution with just a couple portals. And using these different tools where we can preserve the joint so as not to destabilize her. If there's a lot of back pain and the curve is out of balance, then you have to do the fusion because you can't fight the bad mechanics.